Diagnostic thoracocentesis in dogs and cats is performed most often to obtain a fluid sample for analysis, typically after the presence of fluid has been confirmed by thoracic focused ultrasonography or thoracic radiographs. It is also occasionally used to confirm the presence of pneumothorax when ultrasound findings are equivocal, especially in animals that are too unstable to position for thoracic radiographs. The anatomical location for thoracocentesis is the 7th or 8th intercostal space at the cranial border of the 8th or 9th ribs. Most animals that are symptomatic for pleural space disease prefer to sit, stand, or lie in sternal recumbency. Either standing or sternal recumbency positions are fine for this procedure, but do not attempt this in an animal that is sitting, as that will distort the anatomy and make the procedure more hazardous. If you suspect pneumothorax, thoracocentesis should be performed in an upright animal near the junction of the dorsal and middle thirds of the chest wall at that 7th or 8th intercostal space. If the goal is to obtain a fluid sample, the needle should enter the pleural space near the costochondral junction. Take care not to perform the procedure more than 1/4 to 1/3 of the way from the costochondral junction to the sternum, as this is very near the location of the internal thoracic artery and vein. I'm going to demonstrate the technique on a cadaver in lateral recumbency. Animals with respiratory compromise will avoid this position at all costs, as it makes it more difficult for them to breathe. This cadaver has had air injected into the pleural space, creating a pneumothorax, and in lateral recumbency the air will rise to the highest part of the chest wall, near the midpoint between the spine and sternum. The easiest way to find the correct interspace is to identify the 13th rib, then walk your fingers cranially in each interspace, counting from 12 to 8 or 7. The hair coat on this cadaver has been clipped for ease of visualization, but that's not essential for diagnostic thoracocentesis. If time permits, you can clip and prepare the skin for a sterile procedure, but it is also acceptable to simply wipe the hair coat flat with an alcohol-soaked gauze. Note that this holds true only when using a metal injection needle for thoracocentesis. Whenever a plastic catheter is used for diagnostic or therapeutic purposes, the hair coat must be clipped and the skin prepared aseptically. For this procedure, the hand controlling the instrument must be resting on the chest wall. In the live patient, the chest wall moves in and out with breathing, and indeed the entire animal may move during the procedure. If the driving hand is not firmly in contact with the chest wall, you risk losing access, or worse, you risk lacerating the lung. To confirm the presence of pneumothorax, as I am demonstrating here, a 3 cc syringe and a 1-inch long 22 gauge needle is all the equipment needed. Once you've identified the point of needle insertion, you may hold the syringe perpendicular to the chest wall and advance the needle directly into the subcutaneous layer. Alternatively, you can tent the skin, advance the needle into the subcutaneous space more parallel to the body wall, and then reposition it for penetration of the intercostal muscles. Either way, do not advance the needle into the intercostal muscles until the syringe is perpendicular to the body wall and you have applied and maintained vacuum with your dominant hand. Holding the needle stationary with the driving hand, apply a full 3 cc's of vacuum with your dominant hand by pushing off of the syringe barrel finger holds with your index finger and pulling the plunger back with your thumb and middle finger. Maintain this vacuum at all times and use your driving hand to advance the needle into the pleural space. If pneumothorax is present, the vacuum is lost the instant the bevel of the needle penetrates the parietal pleura. When that happens, you have confirmed the presence of pneumothorax and you should remove the needle immediately. If the needle encounters fluid, the vacuum will create a jet of fluid into the syringe. At this point, you can stop advancing the needle, finish collecting the sample, and withdraw the needle as soon as you have collected the desired volume. If the volume of air or fluid in the chest is large enough to compromise breathing, it should be removed with therapeutic thoracocentesis using a catheter or a dedicated chest tube.